and good morning. This is Dr. John Bennett from Miami, beautiful Miami Beach, with Neurosurgical TV. Today we have the pleasure of having Sarath Singhi, neurosurgeon from Sri Lanka, and he's going to give us an insight into the island as well as the neurosurgical backbone of it. And we have Warlix, of course. She's the main hostess. So let me just introduce a few people, Warlix, before I turn it over to you, okay? I'd like to say a special hello to Takashi, who's a neurosurgeon from Japan. He's done some translations for us. He's going to do one for Atugo-L on the 10th. He's also going to do Venko on the 15th. And of course, everyone's welcome for that. And okay, Warlix, I'll turn it over to you, and welcome.
Okay, thank you, John. Good morning from the Neurosurgical TVs today. Today we have really nice topics from Dr. Sarath S.K. Munasajis. He will talk about the neurosurgical practice at periphery of the third world countries, a Sri Lanka perspectives, in which I never been there before, but I've heard and heard for many people talking about. It's really fantastic. So let's hear what Dr. Sarath says. So please welcome Dr. Sarath.
Right. Hello. Hi, John, and hi, Warlix. First of all, I should be very thankful and grateful to Dr. John Bennett for giving me this opportunity. Can you see me, John? Can you see my screen?
So I think you want to make it bigger, right? The slide at the bottom. At the bottom, there's an option. Can you lead them? Oh, there you go. Perfect.
Right. Okay. Right, so this is 1 second. Is it clear now?
Yes.
Okay. Right. So do you see the grid also, or do you just see the presentation?
We just see the presentation.
Okay, that's great. Right. So welcome to to Sri Lankan neurosurgical practice. Especially, I'm going to talk about the practice at periphery of Sri Lanka. This is me, Sarath Munasinghe. I'm a board-certified consultant neurosurgeon at Teaching Hospital Ratnapura, Sri Lanka. So, a few things about me before we start the presentation. So, I was graduated in 2006 from University of Sri Jayawardhanapura, and I started my postgraduate studies in 2010 as a resident. And then I completed my local neurosurgical training in 2017. And I was lucky enough to train under Dr. Himanshu Kularatne, one of the most senior neurosurgeons in Colombo. And also Dr. Saman Vadnambi, who is a fantastic spinal neurosurgeon, as well, and Dr. Jayantha Liyanage, two fantastic neurosurgeons. And then I went for my overseas training. Initially, I started my overseas training at King's College Hospital, London in 2017. Sorry, and then I shifted to Queen Square in London, National Hospital for Neurology and Neurosurgery. So I was privileged to train under almost 40 neurosurgeons. I mean, some of them are big guns in neurosurgery, like Mr. Adrian Casey, Mr. Neil Kitchen, Mr. George Samandiras, Lawrence Watkins, I mean, all big names. So I had quite a thorough training in complex spine and vascular neurosurgery and skull-based neurosurgery, and also in the neuro-oncology, epilepsy, and functional neurosurgery. And 1 second. This is my research interest. So as a general neurosurgeon, we are practicing, we are covering almost all the spectrum of neurosurgery, but I am more keen on super specializing in spinal and neurovascular areas. So I have seen quite a little bit of neurosurgical practice in some parts of the world, like, I went to Rome as a guest speaker, and I went to Dubai as a guest speaker, and I was there in Istanbul Spine Masters, AANS at San Diego, Brighton, and ASIT. I have been to India several times, and I have seen, the big names like Dr. Janaki Ram, Dr. Chandra Prasad Rao, Dr. Atul Goyal, who is a great neurosurgeon. So, and also I have seen, people like Dr. Maika Naimela, Luca Regli operating. So I have been to Riyadh. So I mean, I have seen, a little bit of, neurosurgical practice. Over the world. So this is few of them. And also I'm working I am also editorial board member in the Science Walks Neurology Journal. Okay, that's about me. And hello, can you hear me, Sean?
Yes.
Okay. Right. So this is, Sri Lanka. It's a beautiful island. It's considered as the pearl of the Indian Ocean. So you wanted me actually to take you through as a tourist. So I will show you actually some beautiful pictures and beautiful places in Sri Lanka. But before that, I will just give you a glimpse of neurosurgery in Sri Lanka. So if you take the whole country, there are 9 provinces. Starting from above, you have the Northern Province, North Central, Northwestern, Eastern, Central, Uva, Southern, Western, and this is where I am working currently, which is called the Sabragambu Province, where teaching hospital Ratnapura is. So for these 9 provinces, we have a neurosurgical unit each, where you will see in the next slide. So if you take Western Province, here you have Colombo, which is considered the center. The National Hospital of Colombo it's a well-established center. And then you have Kandy, which is the Kandy Teaching Hospital, which is in the Central Province. Again, a well-established neurosurgical unit. And then you have Teaching Hospital Gaul in the Southern Province, again, a well-established neurosurgical unit. Then we have Anuradhapura, I would say, reasonably established neurosurgical unit there in the North Central Province. And then you have in the Northwestern Province Teaching Hospital Kurunagala, again, a reasonably well-established center. And then you have the Uva Province, where Badulla is a provincial general hospital. I would say it's still, establishing, it's still developing. And then we have the Eastern Province, particular teaching hospital, where I worked for nearly 16 months. And then you have Jaffna, teaching hospital Jaffna for the Northern Province. I think, yeah, it's a reasonably established center. And then you have Ratnapura in the Sabaragamuwa Province, where I'm currently working at. And the neurosurgical unit there is recently established. So it's just 1.5 years since the neurosurgical unit has been established. So it's still a child. So this is just, just a summary of how many neurosurgeons are there in the government sector in Sri Lanka. So starting from the National Hospital, which is considered the center and where the most of the facilities being centered at, you have 6 neurosurgeons. They have a separate epilepsy unit there, and plus 1 pediatric neurosurgeon at Lady Ridgeway Hospital, which is closer to the National Hospital. Then you have 2 neurosurgeons in Kandy, 2 at Gaul, 2 at Anuradhapura, 2 at Kurunagala, 1 in Jaffna, 1 in Batticaloa, 1 in Badulla, and 1 in Ratnapura, where I am now. And there is a separate hospital for the military people, Kotalavala Defense University Hospital. There is 1 neurosurgeon working at the moment. And this is, what I have highlighted here is actually this is Sri Jayawardena General Hospital is semi-government actually. So we have 1 neurosurgeon, a female neurosurgeon there. And in the private sector, I think there are 4, I think at least 4 neurosurgeons there, 4 or 5. So altogether, you can see how many, around 25 neurosurgeons roughly So you can see 25 neurosurgeons for the whole country. This is the National Hospital of Sri Lanka in Colombo. This is the neurotrauma building in Colombo. This is the teaching hospital Batiklo, where I worked until August this year, since May 2019. And this is where I'm working at currently. This is Ratnapura Teaching Hospital. Right. So, as John requested me, I will just go through, a glimpse of the beauty of Sri Lanka. So I thought of, guiding you through the provinces rather than showing some places haphazardly. So this is Western Province, where Colombo is. So you see, this is Colombo, the commercial city, very busy and condensed. Higher population, you can see the Lotus Towers here, Shangri-La, this is the Berry Lake. This is the Central Province, Kandy. This is the one of the most sacred places for Buddhists in Sri Lanka. The most of them are Buddhists in Sri Lanka. So this is called the Temple of Tooth Relic at Kandy, where the tooth, the relic is being kept, of Lord Buddha is being kept at, one of the highly sacred places in Sri Lanka. This is the botanical gardens in Peradeniya. Tourist attractions. This is again UMCC tea plantation. I think this is Houghton Place, again great tourist attraction. This is Southern Province, lots of sandy beaches. So a lot of beautiful beaches you see. This is, I think this is Mirissa, where you see you can do whale watching. This is, I think, Bigwell, very nice beach there. This is Gaul. This is, I think this is Bentota. Yeah, sunsetting at Bentota in the afternoon, in the evening. And this is Gaul again, the lighthouse. This is Yala National Park, where you see a lot of wildlife. So nature at its best. And then this is Duo Province, where Badulla is located. Very famous tourist attraction, Nine-Arc Bridge at Ella. Beautiful waterfalls, magnificent. This is, I think, Bieluma Falls. This is, I think, St. Clair's Falls. This is somewhere in Ella, I think. So lots of, waterfalls, extremely beautiful. This is, and North Central Province, where Anuradhapura is located there. So this is, it's a sacred area, sacred region where, where it has a very, great significance to the Buddhist, where the relics of Lord Buddha, these are called shrines, stupas. So this is called Ruanvali Mahastupa, which is one of the biggest stupas and one of the most sacred shrines in Sri Lanka. This is in Anuradhapura. This is in Polonnaruwa, another closer town to Anuradhapura. This is Galvihara. You can see it's all natural, made of sculptured with with the natural rocks. This one, I think you must have seen this before. This is Sigiriya, magnificent place, right? This is in Dambulla, which is in the North Central Province. This is also Dambulla, the rock cave temple, where you see the beautiful arts made on the natural rock. This is Kurunagala. This is the northwestern province, where you see Kurunagala. So this is the large, the Buddha statue, where you can see the picturesque view of the whole town in Kurunagala, the boat. This is Yapahua again, which has a archaeological significance. This is Puttalam, nice view of the Puttalam Lagoon. Then you go to the northern province. This is Jaffna, the famous Nalur Kovil, the library, Jaffna Library, Lagoon, and the lighthouse. A very beautiful part of the country, the northern part. This is familiar. familiar places for me. This is in the Eastern Province where I worked at. This is the Batiklo Lagoon. Sun setting at Batiklo Lagoon, very beautiful. This is the Kaladi Bridge over the lagoon. This is, I think, Arugam Bay. You see the nice beaches there. Trincomalee Beach, sandy beaches, very nice, very beautiful, very elegant. Pasikuda, one of the best beaches in the country, where you can have a swim, you can have a bath. It's very, very extremely beautiful. And you can see most of the people, they depend on this fishery industry. And this is where I am. This is Ratnapura, Sabragamuva district. You see a lot of waterfalls, lots of beautiful waterfalls. Truly magnificent. So you see the tea plantations, you see the hills. This is Balangoda, 40 kilometers away from Ratnapura. This place is called Kitulgala, where you can do water rafting, one of the famous places, tourist attractions. And when you talk about Ratnapura, I mean, you can't forget gem industry, because when you talk about gem industry, it's none other than Ratnapura. And also the tea plantation. So from a neurosurgical point of view, what I say is, see the way they are hanging there, these baskets. When I ask them, they say sometimes they put 25 to 30 kilograms here. So no wonder I'm seeing one of the, I'm seeing the worst, the cervical myelopathies, lumbar, canal stenosis, and cervical and lumbar radiculopathies. Here, I thought when I was in Batiklo, I thought the worst, these myelopathies I'm seeing in the world are here, but after coming here, I changed my mind. Right. Okay, getting back to neurosurgery. So, as I said, Sri Lanka is a developing nation, developing country. So we have limited resources, limited infrastructure. And if you see the current population, it's 21 million nearly. And you divide it by the 20 neurosurgeons in the government sector, nearly 1 million population per neurosurgeon. So neurosurgeon can be considered as a rare species in Sri Lanka. So today I'm going to talk about the difficulties encountered as a neurosurgeon in Sri Lanka. One thing I need to stress that we are going to talk about how do we overcome the difficulties today. Because as a developing country, we have defects in the system. Defects are there in any system. And that's why we are a developing nation. So when you talk about the deficiencies, so there will be fingers pointed at somewhere, at some point. So rather than, the pointing fingers, what we should talk is that how do we overcome these difficulties? Because, the system will improve with time. But until that, how are you going to survive? So that's why we are going to talk today, right? And the next question, why me talking about these difficulties? Why me talking about the neurosurgical practice in Sri Lanka? I'm still a young neurosurgeon, 39 years of age, early in my career. So there are obviously people who have, who have done tremendous service to the neurosurgical, practice in Sri Lanka. So I may not be the best person to talk on this because, for an example, my seniors might have had, even greater difficulties and deficiencies in their time. So a so-called difficulty for me might not have been considered a difficulty at their times. But this is 2021, right? So technology is at its best, sky high. So we expect a certain amount of, standards in our practice, wherever you are. Whether you are in Colombo, whether you are in Kandy, whether you are in Batiklo, etc., Ratnapura, wherever. So for that, you need to have a proper distribution of your limited resources throughout the country. For example, say one surgeon is practicing and talking about maybe a case series of minimally invasive transforaminal lumbar interbody fusion in some center, while some other colleague in the same country, I mean, even do not have facilities to perform an ACDF, which is considered the basic common procedure today, then you know there is something wrong. Then you know there is, a maldistribution of the resources. So what I believe is each and every individual should have the right to receive the standardized care. But unfortunately, even the basic resources are sometimes not being made available. But that's how the system works. So you have to find ways to get rid of this problem rather than pointing fingers and find out a solution. And that is what we are talking today. That's why I'm talking to you today. Right. So I have worked in Batiklo, which could be considered a place which needs, lots of improvement from a neurosurgical point of view. And the center I'm working currently, Ratnapura, is also a recently established unit. So it has its own drawbacks. So it's accepted. Therefore, I believe that I have something to talk on. So how I tackle my, day-to-day mess as a neurosurgeon, in a peripheral part of Sri Lanka. That's why I'm here. So you gave me the opportunity. And so here I am. Okay. So let's get into the problem straight away. So I would rather say difficulties encountered when you work away from the center. Right. These are the difficulties we face. In some centers, we do have units, neurosurgical unit, but we don't have a separate ward. For example, the best example is Batiklo, where I worked. We have a neurosurgical unit, 24/7 working, 24-hour casualty, but we don't have a separate ward. So where are the neurosurgical patients? Everywhere. Medical wards, surgical wards, pediatric wards. So is it a big deal? No, it's not a big deal. I mean, early in the morning, you have to, walk throughout the hospitals. It doesn't matter. But the problem is, when it comes to authority, I mean, these patients are either in the medical wards or the surgical wards. So during their casualties, then there are a few issues, regarding discharging patients and taking care of the patients, because our medical officers did not have, a place to say. So there were, few hiccups. But to be honest, I mean, almost all the colleagues during my time, they were very helpful. Right, then lack of medical officers. I think this is a universal problem. Even the neurosurgeons in the center in Colombo, some neurosurgeons, they don't have medical officers. Some may be having one or two medical officers. When I started taking over my unit in Batiklo, I had only one medical officer. And there was another house officer who just completed the internship, what we call relief house officers. So the whole unit was run by one medical officer and two released house officers. But we covered 24/7. We covered 24-hour casualties. We did almost all the spectrum of surgeries depending on the facilities. And 95% of the cases training to our hospital, we covered. And we were not very keen to transfer the patients unless it was really essential. And the other problem when you don't have enough medical officers is that, I mean, when you say, for example, when you perform a complex neurosurgical procedure, when you're clipping an aneurysm, you feel you're alone. It's not the feeling you get as a resident when you had some backup, when you had your consultant. For example, I was very relaxed when I was clipping an aneurysm because I had my consultant as a backup. I knew if there was something wrong, I had the backup, I had help. But now here, when you don't have trained medical officers, then you know if something goes wrong, you're alone. There is no one to help. So, you know, a little bit of psychological insecurity. Right. And no MRI machines in some centers where I worked. I think we don't have an MRI machine in Kurunagala yet. We don't have an MRI machine in Badulla. We don't have an MRI machine in Ratnapura where I'm working now, and we don't have an MRI machine in Batticaloa. So it's on the way. So everything is on the way. We have to be patient. So until that, you have to have an alternative. So it's not a big deal because people operated without MRI before. So why not us? Not always. You have to be, you know, selective, circumstantial. I will show you in my next few slides. Right. So sometimes the only resource you have, CT machine, getting out of order. This happened to me when I was in Batticaloa. This happened to me several times. 3 times the CT machine was getting out of order. There was a time that I had to operate. There was a time that we didn't have these CT, the films, frames we didn't have. So what I did was I sent my house officer to the radiology department to get a video of the console. So he comes back, I see the console, and I get a mental image, and then I do operate. So the type of thing we had. So, you know, it's not practical saying that there are no CT films and transferring all the patients you get. It's not practical because, you know, the other centers, the bigger centers, they have, you know, double the work. They have so many patients. Our caseload is very high. And so they don't have time, they don't have capacity, they don't have facilities to, you know, to look after other province patients also. So it's not practical. I mean, you can selectively send, but it's not practical. So you have to find your own solution. And next comes the quality of images. For example, the CT machine I had in Batticaloa, I think it was an 8-slice CT scanner. So, I mean, you can't expect CT angiograms of, you know, a greater quality from that machine. So, you know, where I worked before, I worked at Queen Square, and straight away I came to Batticaloa where there were, you know, hi-fi stuff and, you know, everything is, you know, high-tech. Then I suddenly came to Batticaloa and found that this is the type of quality CT angiogram we have. You know, you can imagine my feelings, but that's life, you have to face it. And I was told that most of the time CT angiograms becomes negative, but fortunately or unfortunately for me, after I went there, most of the CT angiograms became positive. So I had no choice. Right, so then lack of instruments and equipment. This is again, you know, quite a considerable problem we are having at the moment, right? You know, for example, we didn't have pedicle screws for spine fixation. When I was in Batticaloa, we didn't have, you know, cages for these ACDF. We didn't have enough aneurysm clips. We didn't have cranioplasty mesh. And for example, currently also, I'm having, you know, a basic microscope, which is, you know, less maneuverable and it doesn't focus most of the times. And it's very heavy, difficult to, you know, tackle, difficult to maneuver. I mean, we have a lot of problems, but it doesn't mean that you have to stop your all the procedures. You have to do it. That's life. Okay. Then it comes to the lack of ICU beds. Again, a universal problem. So most of the times the neurosurgical procedure is being postponed due to lack of ICU beds. Especially this becomes a problem for you know, an emergency situation because peripheral hospitals, they send the patient intubated and you do the CT and you find acute SDH. and you need a ICU bed for surgery after the surgery. So if you don't have ICU beds, what are you going to do? It's a very difficult situation because in most of our hospitals, the ICU capacity is limited. When I worked in Batiklo, they had just one ICU, but how many surgeons they had? And that ICU only having 5 or 6 beds maximum. Today also in Ratnapura, we have one A&E ICU for our patients, having a capacity of 5 beds. So where are you going to put these patients? It's a dilemma, right? Then lack of trained staff in the theaters, in the wards, in the ICUs, right? So in the theaters also, the nursing officers are not trained sometimes. In the wards, the nursing officers are not trained to manage neurosurgical patients. For example, some people, they don't know how to manage an EVD there. They don't know how to manage lumbar drains. In ICU, most of the time, the ICU is run by, inexperienced medical officers, maybe released house officers. So they don't know to manage complex neurosurgical cases. But, these things we can, we have answers for. We can train them. It takes time. There is a learning curve. But, we have solutions for this. It's not a big issue. Right. Then difficulties in transferring patients. Practically difficult most of the times. Even though you have protocols, theoretically, yes, you can transfer. But practically, when it comes to practice, it's difficult. It's difficult. Right. And especially when you work in the periphery, you see that the majority of the population, they have very low income, they have low educational level, they have lack of transport, less access to hospitals, less facilities in the healthcare sectors. And not only that, you have to tackle with their misbeliefs and misconceptions. For example, I'll show you in the next few case scenarios that you have to do neurosurgery plus, convince people for surgery, change their attitudes, change their misconceptions, misbelief. It's not only neurosurgery you have to concentrate on. It's a holistic approach. For example, when I worked in Eastern Province, most of the people are very poor. If you say to them, see here, you have got a tumor in your brain. You won't say tumor, you say a lump in the brain. Some people would say, okay, I have got a tumor, okay, let's go and do some native treatment. Some people would say, okay, I have got a lump. Doctor, do you have any other method other than surgery to treat this? Can I go for native treatment? Because my grandmother's somebody died after the operation of a brain tumor. This my friend's friend underwent a spinal surgery and thereafter he was crippled. He was bedridden. So I don't want to be, bedridden. I don't want to get paralyzed. Right? I don't want to die after brain surgery. That's the misconception. That's the attitude they have. They don't have trust in you. They don't have trust in neurosurgery. In contrast to the patients coming to you in National Hospital of Neurology and Neurosurgery in Queen's Square, London, they have Googled it, everything. So sometimes you feel that the patient knows better than you, but here they don't know anything. If you say, okay, it's brain surgery, you have 5% chance of infection and 3% chance of CSF leak. You say water leaking through your spinal cord or through the brain membranes. Then they will say, okay, doctor, we have 3% chance of that. Okay, let's go and do the some native treatment like that. It's very difficult. Right. So, I mean, lots of things to talk on, but I think, I will just summarize the things. An inadequate theater time, obviously. I think in some centers, where I work specifically, the theater time is not adequate. I mean, we can't point fingers at anyone. We can't, blame anesthetists because they don't have manpower. They have limited resources. They don't have medical officers. So they can't, give us an adequate theater time. There are a lot of surgeons, but we don't have adequate time. So for example, for the routine procedures, I just had 2 days per week when I was in particular. And here, 3 days per week only from 8 to 2. But still we are doing, 2 major procedures and sometimes 1 minor procedure, co-intermediate procedure. But that's how it goes. So what do we do? Do we practice neurosurgery? Some people might ask, are you practicing neurosurgery with these resources? Of course, yes, we do. So let's see how we, overcome these obstacles and how do we practice every day. I'll show you, I'll go through some of the case scenarios for you. But I want to stress that this is, maybe 2 to 3% of my work. And all these cases are being related to the topic. So these cases may not be the best cases of myself, but these cases have a special significance and they are related to the topic. And that's why I'm taking you through these case scenarios. And also, I just wanted to say that I was never expecting, to present a thing like this. So, I was not collecting my data or any images, in a organized way. So it was really haphazard. So most of the time I don't have enough photographs or videos to show you because the microscope I'm having doesn't have, the screen and doesn't have the video recording facility. In particular, also, I had a better microscope, but the recording function was not working. So what we do is we have a Viber group, in our neurosurgical unit. When a patient comes to us, they put it to us. They put it in the Viber group, and so the pre-op and post-op, the images being put there. So I just gathered few photos from there. Because I was using an iPhone before, and unfortunately I changed to Android phone, and unfortunately I couldn't, back up the Viber, so I lost all my important stuff there. So anyway, let's see whether we can get an idea of it. This is my first case to show you. It's a 34-year-old male presented with headache, altered behavior, anosmia, and visual field defect. The main problem was altered behavior, and that's why she presented. We did the CT. There was a giant, this anterior skull base tumor, and relatives were not willing for surgery, and they wanted to go for native treatment. And not only that, they were not happy to go outside from the city for MRI scan, because we didn't have MRI in particular. So either you had to get it from the private sector, from Colombo or Kandy, or we had to send the patient to the government sector in Kandy to get the MRI. But they were not willing to go outside the city. So this is the tumor they presented with. So what am I supposed to do? I can't force them to, get transferred to a different hospital to get an MRI done. And what I did was, I explained to them, so you have got a big tumor. And these patients were very anxious. It's a big tumor. And, as I told you earlier, the patient being admitted to a different ward because we didn't have a separate neurosurgical unit. And when you admit to a different unit, some people give opinions, especially the next bed patients, they were giving opinions. See, you have got a large tumor, you will definitely die. There were so many, other problems they had. But we operated on her. This is the pre-op without an MRI. So I was anticipating the anterior cerebral vessels either, adhere to the tumor or encased by the tumor. So it happened. So I could find the anterior cerebral vessels very well, and I preserved them nicely. I had a photo, and actually I had a few recorded videos for this one, but unfortunately I had lost it. So this is the post-op. She was absolutely fine after the surgery, and her visual field effects improved. But she developed a CSF leak later, around post-operative day 5. And I had to do a fasciolata grafting to her, and she was absolutely fine after that. No other complications. I'll show you the video of her. This is her. So she was initially very, very aggressive, but she became very funny, and she was very happy finally. So this is her. Okay. Next case, a similar case. 62 years old female, again coming with headaches and personality changes. And she also had visual field defect. And this was very recently, maybe around 3 months back in Ratnapura. So she had this COVID effect. COVID effect means, when the second wave of COVID hits Sri Lanka, I mean, Colombo was more vulnerable. So most of the patients from Ratnapura, they were very reluctant to go out of the city, especially to Colombo, to get an MRI scan done. So I explained to her, you need an MRI, but she was not willing to go out. So I had to operate on her without an MRI because she had severe headache and she had deteriorating visual field effects. We did the surgery. No complications. This is the pre-op. You see the similar type of brain tumor, the similar type of tumor. This is the pre-op. This is the post-op. And this is her. She had no problems whatsoever. Absolutely fine. Another case. After operating the previous case, I got a similar case 1 week after. Again, 65-year-old male, she's hypertensive and had ischemic heart disease. She had behavioral change and, severe headaches, which were not responding to the painkillers, and she was very, very anxious. Again, she had the same problem. She was not willing to go outside because she had a lot of social issues. She was alone, she didn't have any family support, and she didn't want to go out. But she was happy to get the surgery done by us. She had faith in us. So she wanted to get the surgery, but she did not want to go outside. So this is the problem I had, due to the COVID. People were reluctant to go out of the city. So MRI was not practicable during this type of situations. So this is the pre-op. You can see the similar type of tumor. Olfactory groove. This was actually a bit difficult than the other cases. This is the post-op. This is her. Can you see she was very anxious? So it was the subfrontal approach for all three patients we used. But you can see this is after 3 months. Actually, her wound is absolutely fine. Wound is healed, but she had a small, stitch coming out. So we had to remove it after giving some local anesthesia. So even though it's a small, very small wound, she wanted a big wound dressing. That much she was anxious. Okay, another case of tackling the relatives. A 37-year-old female, a mother of 7 children, presented with seizures and change in behavior and social issues. Her family was about to disrupt. So we did the CT, and CT showed a large lesion. Here the lesion. And again, the family was not willing for surgery, especially her husband. He did not want her to have the surgery. So they left against medical advice and saying that we are going for native treatment. And after 2 months, as I thought, she presented with a low GCS to the emergency treatment unit, GCS of 7. So she was intubated, and we asked the relatives, what do you want to do now? Do you still want to go for any other treatment? They said, no, we're happy for surgery. And she was operated following day. Of course, she was unstable with a low GCS, so she was in ICU. So rather than going for an MRI or any other investigation, I planned for surgery straight away. She had ptosis, right side ptosis before the surgery. And she had persistent ptosis even after the surgery, but it was gradually improved with time. This is the tumor, very hard, solid tumor, very firm. You would rather say hard. It's very extremely calcified, and it's attached to and compressing the third nerve also. I thought it was a tentorial meningioma, but I'm still not sure about it. It was a meningioma, it was a fibrous meningioma. And this is the post-op CT. I had a video of her, but unfortunately I missed it. And she got a post-operative CSF leak, which we reconstructed the dura with the fascia lata graft. This is her. This is a photo of her. After the surgery, she became absolutely fine. Her behavioral change absolutely reversed. She was very happy, and I think I was very satisfied that we were able to save her family, which was about to disrupt. And my released house officer did a very good job in convincing her. Because the problem with, these people, they speak Tamil, and I'm Sinhalese, so I don't know much Tamil. So I had that language barrier also. So whenever I communicate with them, I communicate through my medical officers. I mean, all 3 were Tamil. But the problem is when when you communicate through some people, you communicate with someone, you communicate through someone else, sometimes what you want to tell will not be communicated as it is. So that was another disadvantage. I wouldn't say disadvantage, another drawback, right? Another one, 24 years old female, presented with seizures and right-sided lower limb weakness. Surgery planned in another center, and she didn't turn up on that day because of fear for surgery. And she came to us because she was from close by. All these cases were done in Batiklo. She was from Arugambe, close by, so she came to me, and I had to convince her that the chances of her dying are very low. And we operated on her. She had right-sided weakness, a large parasagittal meningioma. We had to tackle with the sinus. This is the post-operative CT. She was absolutely fine. And this is her video. She was young, she was unmarried, she was anxious, and she was absolutely fine. Okay, the most scary day in my neurosurgical life, which I can never forget. 42 years old female, change in behavior was her main problem for the family, but she had seizures which was not controlled with medication and left-sided body weakness. she was really, really anxious. This is what she got. See the tumor? See the carotids? Definitely, the carotids are encased by the tumor. The middle cerebral arteries encased by the tumor. So after seeing this, this MRI, I said to her, I think you better go and consult another surgeon, maybe in in a center with better facilities. But she was reluctant to go there. I don't know whether she has gone there, but according to her husband, she has gone there, and she was reluctant to get it done by someone else, especially away from her village, away from her home. So what she told me was, this is my village. Even though I die, I want to die here. So I have faith on you. So please operate on me. That's what she said. Then, I was actually trying to convince her. She was coming to see me so many times. I said, see, this is a difficult tumor. We have got very limited resources. So, you can die on the table. We can damage the carotid artery. But I don't know, maybe because of her, psychological abnormality. She was, she was, I would say clueless. She was really different. She was not listening to us. And all the relatives, the husband, they requested us to do the surgery. Okay. So then I said, okay, I'll do the surgery. So let's fix the date. And that was during the first wave of COVID. I think it was in January or February, as I can remember. So I did the surgery. And, my heart was pounding when I started the surgery. I knew what's going to happen. I knew that there is a high chance, I could damage the carotids. So we were ready with the aneurysm clips and we were ready with the sutures if something happens. So I know this is not an educational webinar. So this is just an informative webinar, but I just wanted to show you that, I was trying to, follow, all the correct techniques. The tumor, we calculated the tumor capsule, incised, right, debulked it, and then I identified the MCA branches and followed them proximally to establish a dissection plane. And the tumor was very, very, very firm, extremely difficult to remove. I used the CUSA, but it was not successful. With the diatom, you can't do that. So I tried to use the sharp dissection with the scissors and removed in a very piecemeal fashion. I tried to recognize an arachnoidal plane, but it was very thin and obliterated. So since the tumor was too adherent, I left a small sheet of tumor on the vessels, on the middle cerebral vessels. And then finally, I could identify the tripartite artery, the paraclinoid segment, the optic nerves, and the third nerve. And then what I did, I realized that the artery is very thinned out, very much compressed of the tumor. And there was some bleeding. So I tried to coagulate that bleeding with the diathermy. And suddenly I found I have made a tear in the carotid artery, which was, very accidental. And I didn't expect that. And since the arterial wall is very thin, there was, sudden gush of blood, like opening a tap. So you can imagine a bleeding from the carotid artery. So I was very, very upset, and I was very, very, very frustrated at that time. So because I knew what was going to happen. See, so I was telling to myself, see, this is what happened. I told, right? So see what we are going to do now. My medical officer was shocked, and the anesthetist was shocked. You see, like a tap, the blood was coming out at rapid speed. Anyway, I was able to apply 2 clips and get the control of the artery. And we already had brought 10 proline from the eye theater. So I was luckily able to suture the tear. And I could control the bleeding. So my heart was in mouth that day. So obviously she had a swelling in the brain immediately. She had a post-op swelling as well. We paralyzed and intubated her. So we kept her on paralysis for 48 hours. And I went to my room that day and I told my wife, see, I think I have killed this patient, right? And I said, I don't know why she wants to die on my hands, right? I was really upset on that day. But fortunately, on 5th post-operative day, she was gradually becoming better and better. And this is her. This is, I think, 6th post-operative day. And that, I mean, this case, I will never forget in my life. Okay. Another case, handling difficult cases with minimal resources. This is a 43-year-old mother with 10 children. She was the only breadwinner. She's widowed, and she had 3 children less than 5 years. She presented with rapid loss of vision and ptosis. Again, she was not happy to go out of city. I mean, obviously, in her case, she had valid reasons for that. She had 10 children and 3 children less than 5 years. She was the sole breadwinner. So she was Tamil. She didn't know the language. So obviously, she did not want to go outside the city. What has she got? What she got was, I don't know whether you can see, whether you can appreciate here. She got probably a cavernous sinus meningioma, a cavernous sinus lesion, probably a cavernous sinus meningioma. This is the tumor. So I knew this was going to be a very tough one. So again, I'm just giving you these the steps I followed to tell you that I was trying to follow the absolute correct technique. I did a front orbitocytomatic osteotomy, built the sphenoid bridge. I identified and dissected the meningoorbital band, did an anticlinodectomy, unroofed the optic nerve, explored the cavernous sinus to the Parkinson's triangle, and identified the 6th nerve, and I resected tumor. There was heavy bleeding, but I was able to control that. And this is her. This is the pre-op. You can see the ptosis, right? Her vision was very much deteriorating. This is post-op day 1. And her vision was already got better. And we did the visual fields after that, and she got almost 90% of her vision back. Very satisfying surgery. Another case, difficult case. Again, did with the CT, no MRI. Meningioma, a tough one. And video 4. There she is. Absolutely fine. Right. Okay. Another case. This is actually a glioma. And you may be wondering why I am showing this to you. We have done so many gliomas. I mean, I'm not showing you any of the straightforward cases we did. So a lot of gliomas we have done. But this one we did without an MRI. So I usually don't operate gliomas without an MRI. But this patient, a young patient from Ratnapura, actually from Balangode, she was really anxious. And again, because of the COVID, she did not want to go out. She did not want to go out of the city. I don't know. I mean, it actually, as a neurosurgeon, it was, really difficult situation for me because these patients were not happy to go outside, even for an MRI. So I had to operate on her without the MRI. And we don't have the navigators in Batiklo or in Ratnapura. Most of the centers, we don't have a navigator. So you do a glioma without navigator, so you have to be spot on with your craniometric points. So this is the pre-op. So I explained her, usually I'm not doing surgeries without an MRI, but since you are requesting it, I'm going ahead. but these are the possibilities, these are the complications, and you need to have radiotherapy later. So, but she agreed, she accepted that. So this is the first one and only one I have done without an MRI. So this is the first resection. I felt that the resection was not very adequate, so I kept her. Usually I don't do contrast CTs within the first 48 hours of a patient after glioma, but this one I thoroughly felt that I haven't resected completely. So you can obviously see there is a residual, so I kept her. I did the second resection again, and we did the MRI post-op. Now she was happy to go for an MRI because she was happy. And she didn't get any, complications, and her vision was also getting better and better. So we had a minimal residual, maybe less than 10%, and we sent her for radiotherapy. So this is her. Let me show you that again. So she didn't have any residue. She didn't have any, complications. Right. This one, cerebellopontine angle tumor. One of the best I have ever done, because this was very early in my career as a consultant when I went to particularly large tumor. This is the patient post-op. We don't have these cranial, we don't have the spatial monitors in our centers. So I did this with the suboccipital approach rather than the retromastoid approach, because I was used to this approach better than retromastoid approach. And I thought the tumor was a bit bigger, so that's why I used this. And here he is. No facial nerve palsy and complete resection. So that was a big achievement for me in my life as a young neurosurgeon. Another CP angle which I recently did, left-sided. The problem here, as I told you earlier, the microscope is not very maneuverable. I mean, it's difficult to handle. So left-sided tumors, I mean, we had problems. I will show you later why it happens, because this was the first CP angle tumor I did. Soon as I went to Ratnapura, so I was, just learning. I was on my learning curve regarding the tech. I mean, regarding the ergonomics and regarding the the positioning, and regarding the microscope also, I was not very familiar. So we positioned her arc bench position, lateral position for a retromastoid craniotomy. And I did a retromastoid craniotomy and tried to open up the CSF system, the CB angle system. But I found that the cerebellum was very tense and it was coming out severely edematous and I couldn't do anything. Then I realized, I mean, if you still go ahead with the procedure, so you will end up in damaging the vital structures. You will end up in taking her cerebellum out. So what I did not harm the patient. I realized, understood the situation. I abandoned the procedure. I closed the posterior fossa incision, and I inserted the VP shunt on the right side. And I woke her up. I explained to her, see, this is what happened. We have technical difficulties in operating your tumor here, so I will send you to somewhere else where you have, proper facilities. And then I readmitted her to my unit, but unfortunately, by that time, the second wave of COVID has hit Colombo. So difficult for me to go there, or difficult for me to, to send this patient there. And she was also happy to undergo the operation at Ratnapura. And by that time, I had done another 2 CP angle tumors on the left side. So I found out the way I found out what you should do. And I was able to resect the tumor completely. And here she is, no facial nerve palsy, absolutely fine. This was another CP angle tumor I did before the previous case. Again, a left-sided tumor. So by that time, I have found the way. I have found the techniques of using the microscope and handling it. So this is the pre-op. Again, MRI was not available. It's not because it's not available. She did not want to go out. That's the problem with these people. Even how much you try to convince them. This is, the problem with them. Sometimes they don't understand. Sometimes they don't listen to you. So this is the post-op. Preoperatively, she didn't have hydrocephalus, early hydrocephalus, but she developed the hydrocephalus, so I had to insert a VP shunt for her also. She unfortunately got a facial nerve palsy, but otherwise she was okay. She was having swallowing difficulties also, but it's settled with time. Okay, let's get into some difficult pediatric cases. This is a 6-month-old baby with a large cerebral abscess, and he was having a congenital heart defect also. So the abscess was aspirated in some other center and sent to her local hospital, which was closer to Batiklo. And since the fever was not settling, they referred back to us. And this is the abscess before aspiration, and this is after aspiration, so it has grown in size. And the child was having congenital heart defects also. There was some anesthetic issues as well. But the anesthetists were very good. We were able to give the child anesthesia, and we were able to operate on her. So I excised the abscess completely because this is a large abscess. I thought of excising it, and I excised it. And you see the fever chart before the surgery, high fever. And this is the day we operated. The child was sent to his ICU, no fever. Immediately, you see, there is no fever. Right, so I'll show you the video. I think I'm having that. This is the child moving all the 4 limbs and active without any fever. Okay. And right. I'll show you some of the neurovascular cases because I told you I'm very fond of these neurovascular territory. First case, 49-year-old male, previously healthy, and had a sudden collapse around 7 p.m. where we saw him at the ETU with the GCS of 11, which was dropped within 3-4 hours to 7, so we had to tube him. And unfortunately that day, CT machine was out of order. That's why I'm showing you this case. And we were ventilating him, paralyzing, and the midnight, his left pupil started to become unreactive. So we operated next morning. I had no other option. No CT angiogram, therefore no CT angiogram. Young patient, sudden collapse. So we obviously anticipate some neurovascular scenario here. So we were ready with aneurysm clips, and depending on the available facilities, we were ready. This is the post-op CT, you see. He was a translator, and the problem I had, he's a translator, so there's a high chance that I would further compromise his language area, eloquent area. So I was very careful. This is the post-op CT, and it was a cavernoma, macroscopically, cavernoma, and this is him. This is post-op day 5. This is him last week when I saw him in the wards. He was slightly He was initially aphasic, but he's having a remarkable recovery. He can understand and he can speak few words. I'm sure he will come out with good results. Right, another one. 12 years old girl with a left parietal ICH. Initial GCS 14, dropped to 12. We did the CT angiogram. Spätzle-Martin grade 3. AV malformation we have found. So you see the clot here. Again, eloquent area. So have to be careful. This is what all you get. So this is our CT angio. I saw this in the console, but I mean, you can't expect more from a 16 slice CT scanner. And my radiology colleagues are fantastic. We have 3 radiologists at Ratnapura. Fantastic guys. This is the intraoperative picture of the brain. It's very tight. This is following the resection of the AVM. This is the post-op CT. Just for the comparison, this is pre-op, this is post-op. This is the post-op again. And this is the video of her. This is post-op day 3. She was remarkably doing well after post-op. She initially had some, deficits with her short-term memory, but I saw her in the clinic. She has almost 90% recovered, and I'm sure she will recover fully with time. Satisfying surgery again. So we see lots of intracerebral hemorrhages. When I was in Batiklo in the Eastern Province, and still in Ratnapura also I'm seeing so many various types of intracerebral hemorrhage. This patient was on warfarin, presented with a GCS of 3, and that's why I'm showing to you. So what I used to do, we don't have the endoscope. So what I used to do is Verhall for a mini craniectomy and evacuation of the clot. This is the pre-op. This is the post-op. You see, I'm showing this to you because she presented with a GCS of 3. And this is after 2 weeks. This is after 2 weeks. So a good result, a very good result. Right, another ICH, the same thing I did. Patient went home, GCS 15 without any deficit. Another one, you see the Burhall evacuation. Patient went home. And this is some, some of the measures of the CT angiograms we had at Batiklo. This is all what you get. You don't get, these sophisticated hi-fi images, right? You don't see this ICG, and you see this film only before the surgery. So you have this film, you get a mental image. I don't know whether you can see the aneurysm. You see the anterior communicating artery aneurysm here. Here also you can see anterior communicating artery aneurysm here. That's all you have got. So you go ahead. We clip this. This is only a few of the cases. This patient, obviously a young one, but he developed myocardial infarction on the postoperative day 3, and he passed away. Otherwise, his post-op CT was fine, but I couldn't find the post-op CT in my phone. Right. This is another scenario. Recently it happened. 44 years old female, hypertensive with defaulted treatment. SH presented with a GCS of 3, and there was a large PCOM aneurysm, 1.9 centimeters. Bedside echo we did, ejection fraction was 35%. So the question for me, operate or not? Ejection fraction 35, GCS of 3, but 44 years of age. Anesthetists were asking me, are you really going to operate on this patient? I said yes, because she's still young. So let's give her a chance and see. And I don't have, unfortunately, a post-op CT for her. There is she. So she had 0 power on the left side initially. So now she's gradually improving. We did tracheostomy for her. She's still on, still improving. We did another 2D echo following the surgery, and ejection fraction came as 50. So I'm happy that I operated on her. Okay. Few spine cases for you. We did a lot of spine cases, but these are only few of them which are important to the topic. 12-year-old boy, previous tumor excision 1 year back, presented with left lower limb weakness with 3/3 out of 5 power, 18 type 2 neurofibroma. Yeah, dumbbell tumor. I don't know whether you can see the tumor here. So this is the tumor at T10, T11 levels. This is the tumor, big one, a dumbbell tumor. And we did the surgery with the posterolateral approach with left-sided costotransversectomy. And this is how we did. He couldn't walk before. And this is immediately after surgery, moving with difficulty. Very poor people, even did not have money to come to the hospital. She told me that they need 50 rupees. 50 rupees is $0.25 to come to the hospital and go back. But I mean, they were so poor that they were unable to find 50 rupees to come to the hospital. So I kept him quite a few days. So this is post-op day 2. This is after 1 week. This is after 1 week. Getting better. Still a bit unstable, but getting better. Right. This is after 2 weeks. I kept him in the ward. See? See the improvement. So we kept him for 3 weeks and gave them physiotherapy. Right. Okay. Another one. Interesting case. This patient with neurofibromatosis type 2 presented with bilateral lower limb power 1 out of 5 for 1 year and bilateral upper limb power of 3 out of 5 for the last 6 months. They were from the Eastern Province. They were from Ampara or Mahawaya, which is in the Eastern Province. And I have seen them when I was in Batiklo. And since I shifted to Ratnapura, they contacted me and they came all the way to Ratnapura to get the surgery done. So she had these bilateral schwannomas, probably. And if you see the cervical spine, you see a cervical spine tumor here, 2, 3, 4, 5, 6, 7, yes, 6, 7 level C-spine tumor. Here you see the C-spine tumor there, and you see another thoracolumbar, L1 tumor there, and you see another, where is it? Another tumor here. You can see the quality of the images are not that great anyway. So she presented with three spinal tumors, cervical, thoracic, and lumbar, and 2 brain tumors. So what we did the first I did the thoracic and the lumbar tumors at one go, it came as meningothelioma meningioma. And then I did the cervical spine. After some time, it came as a schwannoma. And her power was 0 in the upper. Her power was around 3/5. As I mentioned pre-op, this is her last week at the clinic. 5 out of 5 power in the upper limbs. Still the power is around 2 out of 5 in the right leg, and the left leg is around 1 out of 5. Okay, and she's awaiting the post-operative MRI, as well as I'm thinking of doing the posterior fossa tumor as well. It's a good case. I think we can talk about this later on a different day. Another case, 51-year-old male with a previous surgery done. Again, he had a recurrence of tumor. I forgot to tell you, this patient, there was a delay from the patient's point of view to present to the hospital of 1 year because they have done native treatment. Very unfortunate. 20 years old female ending up in the wheelchair. Yeah. So this case, 51-year-old male had previous surgery for the cervical spine tumor and had recurrence of tumor and presented to us with a bilateral upper limb power of 2 and lower limb power of 1. He had very poor family support, and again he also had gone for native treatment, and he presented with an Eden type 2C dumbbell tumor. So what we did, you can see the tumor, dumbbell tumor to type 2C. So the vertebral artery was adherent to the tumor, and what we did, we went through the posterior approach, and I removed the 100% of the intraspinal component, and I could only remove 80% of the extraspinal component. And you see the video here. This is him. Bit of improvement. On the left side, he had a power 0 in the lower limbs. Improved. This is 5 days after the surgery. So significant improvement on the left side. A bit of improvement on the right side. Okay. Another one. Patient with no family support at all. Patient is all alone. She's living alone, and she has no proper place to stay. Presented to us recently with lower limb weakness of 3 out of 5, and started deteriorating, and her power was 1 out of 5 when we sent her for an MRI to Colombo. And she came back to us with the 0 power preoperatively. Unfortunately, the MRI machine went out of order when the MRI was, in the process. So we did not have films, so we had only the report. The report says there is a T4 lesion. So what am I going to do? Am I going to send her back for an MRI, another MRI? No, I had to operate on her because she was deteriorating rapidly. So the first time I operated without a film, T4 lesion. So this is what happened. Zero power before the surgery, and okay, right. Few pediatric cases for you to show. This is when I practiced in Batticaloa, the Eastern Province. you see so many types of hydrocephalus. You name it, we have it. Holoprosencephaly, hydrodancephaly, right? Each and every type. Hydrocephalus. Lots of neural tube defects. See, this is only maybe 10% of our work. We've done so many. Okay, that's all about the cases. Right, so this was a glimpse of our work. So now I'm showing you, this is the microscope I'm using at the moment. The basic microscope you can see, but this is how we overcome. So this is what we have done so far with this. We don't have a separate covering for microscope. This is how we cover it. Okay, this is the theater setup in Ratnapura. This is where I'm currently working at. This is the neurosurgical theater. Now you can see we have the illuminator. We put the CT there and we just take a photo. We don't have this computerized system where you can access the PACS, where you can access your images through the PACS system. So we don't have that system here. And this is the previous station. This is Baticlo. So you see the screen there. So it was a much better microscope, much better facilities you can see. Okay, one more case to show you the difficulties we are facing every day as neurosurgeons. This case, gift for me on 31st December. Patient presented with SH, GCS of 3, and we found this large aneurysm, this supraclinoid aneurysm, and the CT angio. This is the aneurysm. So you can see my radiology colleagues did a great work to provide me this this thing. So what happened, unfortunately, and we dissected, and the severe brain edema was there, and I saw just a glimpse of the dome under the clinoid process. I was about to drill the clinoid, but unfortunately the microscope stopped functioning. It was not focusing anymore. So what should I do? Should I proceed? Large aneurysm, drilling the clinoid without a microscope? No. I said it was not safe. What I did the decompression. I did remove the CSF, so the brain was relaxed. I wrapped the aneurysm, the fundus which I could see through my opening, and I abandoned the procedure. I came back. I cannot transfer her at the moment for coiling or any other because she's not stable. She presented with the GCS of 3. So she's being still ventilated. I explained to the patients, the relatives, the procedure. So these are the, the difficulties we encounter, right? Just to show you, right? So see, they were trying to fix the microscope. They thought it, because of the covering they use, it was not functioning. The aneurysm clips. So see, that's the facilities we have. Just one clip applicator, just one clip remover. Okay, here the patient. They didn't know that I was recording. Okay. Okay, that's the situation here. This is my team, right? They haven't had much neurosurgical practice. Now, this is my released house officer. This is my MO. They were doing a VP shunt together under my supervision. So now they are happy because satisfying with their work. Here they are doing an acute SDH. They were just doing chronic Burhall evacuation of chronic SDH. But now I think they're enjoying. This is my neurosurgical unit, female, the ward. I'm having 3 beds at the moment. This is the male unit. This is on 31st of December, so we have discharged most of the patients. 5 beds are there. This is my ward team. So, the take-home messages, especially to the juniors, when you work in, away from the center where your facilities are centered at. First thing, I would advise do no harm to patient, whatever the instance, right? Because you're bound to do that. Whatever the protocol or policy, that's number one. So if your protocol threatens the life of your patient, then what's the point of following the protocol? So at any instance, do not harm the patient. Understanding human nature, right? Understanding what life is, right? Listen to the others. And be sympathetic always. Understand the patient's feelings, their priorities, attitudes, concepts. That is especially important when you work, in a rural area, right? The patient's beliefs, misbeliefs are there, misconceptions are there. Sometimes you have to work hard more on it rather than neurosurgery to change them, right? Humans are humans everywhere. We know that. So always treat patients like your mother, like your father, like your relative. Always think, if it happens to your relative, your family member, how are you going to manage that? That's the most important thing. Understand the circumstances. You have to be flexible, right? You should not have a strict policy. For example, I'll give you a case scenario. If a child comes to you with a large ICH and low GCS, and she deteriorates in front of you, and imagine if the pupils start becoming non-reactive, you highly suspect an AVM in this case, right? A young child with an ICH, and see that you don't have access to CT angiogram or the CT machine is out of order, what would you do? If you ask that question from me, what I would do, I would explain the relatives, the parents, the condition. This is the situation. See, the child can die during transfer, right? There is no such system in our country that the neurosurgical patient is directly going to a neurosurgical theater in a different center. So obviously there will be delays, right? So we properly communicate that you're going to do the surgery to save the child. So communication is of utmost importance. At the same time, you should have, an insight to what you are capable of. You should know whether you are capable of doing this, right? Have you done AVMs before, right? If so, do you know how to get rid of the mess when things go wrong? Things can go wrong. People might point fingers at you. Why didn't you do this? Why did you do this? And why didn't you do this? It's very easy to, talk, very, very easy to tell. Words are very easy, but, doing it is very difficult, right? Finding faults are very easy, but, doing something is very difficult, right? There is a learning curve for any surgery. For complex neurosurgical cases, it's much, much longer. That's why you need experience. So if you are confident and you know how to get rid of the mess, provided you have the basic facilities at least, I think you should proceed. You should go ahead and do the surgery. You should not be overconfident. Confident, but not overconfident. If you are overconfident, you will kill both your patient and yourself, right? And you should try to get the maximum out of what is available to you rather than pointing fingers, rather than saying, oh, I don't have this, I don't have that, I can't do this, I can't do this, I can't do that, right? This is how the protocols are, this is how the guidelines are, this is what you should do, but try to get the maximum out of what is available. That's what I'm doing. Right. So respect your seniors. You need experience. It takes, time to get the experience. That's why you need guidance from your seniors, right? That's why you respect skilled and excellent surgeons, right? Some people are well skilled, some people are less skilled, some people are fast learners, some people are slow learners, right? So I need to give and not at last but not least, enjoy life. You can enjoy your life in the periphery, right? So quick word regarding my colleagues, neurosurgical colleagues. When you talk about neurosurgical practice in Sri Lanka, you can't forget them. It's not just me. It's it's a group. So all the 25 neurosurgeons are working in Sri Lanka. Fantastic, skilled neurosurgeons. All of them doing a tremendous service to their country, right? All neurosurgeons at National Hospital Colombo doing a great job. My boss, my mentor, Dr. Kularatna. I should be extremely thankful to him. He is the one who identified my skill and gave me free hand. So by the end of my, by my local training as a senior resident, I had done more than 40 aneurysms. People, when I went to UK, I told this, people were thinking that I'm lying because, 44 aneurysms in 2 years is a very, huge amount. If I'm in a position today, it's because of them, right? So I'm very grateful to them. And I should mention Dr. Deepa Latanayak, who is the president of the Neurosurgical Association. He's very keen to on improving the standards in our country. And Dr. Sunil Pereira, who is, a very popular character and considered the best neurosurgeon in Sri Lanka, has done an unforgettable service to the country. So wherever they are, they're in Anuradhapura, wherever they are providing a huge service to the country. For example, if it was not, for the previous neurosurgeon who worked at Ratnapura, who got this microscope for a donation, I wouldn't have, I wouldn't have, done this presentation. I mean, the most of the presentation without a microscope. So I'm very grateful to them. Right. So, the life is not very easy. It's difficult, right? It's difficult. It's very unsure, right? I'll just tell you one story and I end my talk, right? I think I haven't told this before to anyone. When I was in UK, when I first went to UK, I was in, I went to King's College London. I didn't have the hospital accommodation. So I was staying in a very small room in a small hotel. The first day, I slipped in the bathroom. I hit my head on the edge of the bathtub. I don't know whether I was unconscious for a few minutes or not, right? So I didn't know what happened. Then I woke up and I feel a little bit of headache. And I said I was completely okay. But I persistently had this headache for few weeks. But I was just starting my overseas training, so I was very reluctant to tell them and to get a CT scan or an MRI done. So I said, okay, I think I'm fine. But you know what happened? After some time, I realized that I was losing, some of my long-time memory, right? For example, I can still remember this, every day we have this MDT meeting for the residents. So the neurosurgeons coming and the residents coming and they're presenting the cases. So one day they ask questions from the residents. They ask from me, tell me the causes of hydrocephalus, the basic medical student question. Right, so I had done, you would have seen, I had done research on hydrocephalus. So I had read lots of books, Schmeidick and Sweet, Yeomans, Rengachari, everything I could tell from A to Z regarding hydrocephalus, but I couldn't answer that question. I was blabbering, I was saying increased production, reduced absorption, I was shocked. And people were shocked, people were laughing at the back of me. SHO, so I was a senior fellow. I went as a senior fellow, but I couldn't answer that question. So I had that intermittent loss of memory. So I was really frustrated. I couldn't tell that. I couldn't tell that to anyone. So I was really, really frustrated. I went back to the room. Then I started from A to Z. I thought, oh my goodness, my neurosurgical career is over now. That's what I thought. Then after 1.5 months, I came back to Sri Lanka and I did a CT, I did MRI, that was normal, but I had the problem until 8 months. So, it was terrible. It was horrible experience I had initially because I had King's College Hospital is, a terrible place. Terrible, I mean, very busy, extremely busy. It's one of the best centers in UK. I know that it's very, very difficult, when you especially start with coming from a different country. And when you get personal problems like this, and on top of that, you hit your head and you lose your memory sometimes, it's very difficult. So, but, I was able to get rid of that problem. After 8 months, I was on my own, back to normal. Right, but I'm quite sure that people must have laughed at their backs. It doesn't matter, right? then I realized I need to move on. So after 15 months of training there, then I applied for UCLH, the Queen's Care Hospital, and I was lucky enough to go there. And things changed. That was the turning point in my life, neurosurgical career. Then I had to compensate for the things I lost. So I went to so many countries, I met so many people, did so many researches within, you would have seen in a short period of time. And I was completely okay, and they helped me very well. They believed in my abilities. The people at Queen's Square, I'm very, very grateful to them. And fantastic time I had. I just told that because, sometimes my colleagues at King's College, they'll be wondering, hey, see, that man is appearing on YouTube now, he's doing international webinars. How come? Probably he might have stolen some of the other people's cases and presenting it. So, right, so that's life. So, it's very hard. And now I'm back to my own. And yeah. So what I need to do, I need to provide the better service to the country. That's it. So that's how we do. So, right. I think that's the end of my talk, John.
Okay, great. In many aspects, from the tourism part for me, and the rest of the issues you talked about. But let me turn this over. The neurosurgical aspect of it was very interesting. I'll let the irrepressible Warlicks lead the neurosurgical discussion. Hey, Warlicks.
Yeah, thank you for your talk. It's so like inspiring, like young neurosurgeons like me, and I think that is good for the neurosurgical residents from all over many countries too. So it's time for the discussions and questions, or even like suggestions to the floors. If anyone have questions, you can ask Dr. Surat about it.
I think Eamon has a question. Eamon, do you have a question there? Are you raising your hand? Go ahead, Eamon. We can't hear you, Eamon. I think you need to unmute.
Yes. Can you hear me now?
That's better.
Yes. Thank you, John, for this lecture. Thank you so much. And thank you for the doctor, because he is inspiring and he is doing a great job. But my question, how he is doing, how is the tumor resection or removal without doing MRI before, before the operation? How he can recognize the cleavage plane, if there is any encasing vessels or important structure. I hope he can answer this question and answer, because I think it is important to do MRI before the resection or the operation of tumor resection. Thank you.
I agree with you. Yes, Simon, I completely agree with you. That's the challenge in this part of the country. So that's the problem. So that's why I was selecting these cases. And we have done, so much cases, routine cases with MRI, which I have not discussed here. So I have just discussed this. The few cases which I have done without, having an MRI, which is really difficult. I agree with you. So that's why I said, you have to anticipate. That depends on, your experience, what you have seen, what you have done before as well. So as a resident, I have done, so many meningiomas and so many gliomas. So I anticipate these are the problems that we would encounter, and you have to be, you should be anticipating this, and you have to get ready for this, right? So in that situation, to answer your question, it's a difficult thing. So it's a intraoperative, it's your intraoperative decision that will depend on how you have gathered things together during your neurosurgical life, neurosurgical career. Sometimes things might go wrong, sometimes things might succeed. So fortunately for me, I succeeded, but everyone might not succeed. That's why the communication is very important. Before the surgery, you have to discuss with the relatives. So this is what you got. This is what we anticipate. This is what could happen. You go without this. Obviously, people have operated without MRIs before the invention of the MRI. But as I said earlier, this is 2021, right? Right. So if something goes wrong, people will point fingers at you, say, "Hey, man, that man is doing without an MRI." So if something goes wrong, how are you going to justify? That is dangerous neurosurgery. Someone will point fingers at you. Absolutely right. That's what I'm talking about. So that's why I'm always telling you, you have to be circumstantial. You have to be flexible, right? You should not have a strict policy. If I were, right, say, for example, that those cases, if I were to send those patients back, telling, no, I can't do this surgery. You go to somewhere else, right? I would have missed that. There were certain instances that we missed the patient's lives, right? We asked them to go for MRI. They never went there. They presented with the GCSF3 and they died. I had bad experiences. So that's why I always try to think of from the patient's point of view, patient's aspect, right? So it may not be the best for you, but it may be the best for the patient.
Thank you. Thank you. Clear. Thank you. Confident, not overconfident. Thank you. Yeah. Thank you.
Yeah.
Takashi, you have anything to say, Takashi?
Yeah. Thank you for a great lecture. So a very informative lecture, and I appreciate. Even though the limited circumstances, you did very well. Thinking of the patients, really appreciated. I would ask about the glioma patients. So you removed the glioma, then after surgery, the patient went on the radiation. So in Sri Lanka, so temozolomide and chemotherapy, such as temozolomide and bevacizumab or some other chemotherapies available?
It's available. We refer the patients to the oncologist, so they take over the patient and they do the chemotherapy and radiotherapy and everything is there.
So in Sri Lanka also you refer the oncologist for chemotherapy?
Yes, that's true. We refer to the oncologist.
Okay, thank you. Yeah, they did a great job. So
thank you very much.
Expect the future success.
Thank you.
Okay, Warlocks, keep it rolling. Are you there, Warlocks? Warlocks, you taking a nap?
Just waiting for other comments or the questions from the panelists.
You were eating, weren't you?
No.
Oh, no. Okay. I thought I caught you.
No,
can I ask a question?
Yeah, of course. Go ahead.
From Voralex. So she's from Thailand. So how is the neurosurgical practice in Thailand? How is the technology-wise like?
Oh, we have in the medical school, we have everything, like even the robot. So I just finished my trainings like neurovascular and endovascular. So I have can do both of things now. Yeah.
Okay.
So yeah. So it's a challenge things, and I think it's in Thailand we have a lot of things. Yeah.
Okay. That's great. So what is your conception regarding doing surgeries, without proper angiograms, without proper MRIs? What do you think? If it happens to you, what would you do?
If I have a limitations, actually I'm talking about my own experience then, because after my trainings I have to move back to work at the smaller hospital in which we do not really have an MRI available. So it's depend on me if I consider that so as what you say that it have to be selected. Sometimes if that case I consider that there's no need to do an MRI in which there's no need for that, no dangerous neurovascular structure. So sometimes it take too much time to do MRI. Maybe I prefer to do an MRI for the follow-up post-operative. But for sometimes especially aneurysm case, of course that sometimes CTA it's very necessary. But right now I think that CTA reconstructions with bone is also like helpful too. Some like in my center that I just got trained, they hardly do the angiogram, but they prefer to do the CTA with the bone reconstructions, which is also like helpful. You just like have to improve the quality of the CTA, so it also can replace the invasive angiograms too. But even like for me, I'm talking like even your country do not have a DSA. I mean digital subtractions
No,
angiogram.
we do have DSA.
You have, right?
DSA. We do have DSA in Colombo. We do have DSA in Kandy. We do have DSA in, in 3 or 4 places.
Wow.
So if the CT angio is negative, we send definitely for the DSA. We follow the protocols, but what I mean is, when it comes to, some circumstances which are unavoidable,
Yeah.
then you have to think twice.
Yeah, in my countries, there's even the endovascular treatment is still like problems too because about the financial problem. So of course, so we still have to like based on the microsurgeries, we still like need to practice the bypass, creeping reconstructions, or proximal control instead of using the balloons. In which I trained to use the balloon, but of course like once that we have to select the case because one balloon that maybe it can cost more than like one surgical case. So yeah, in the developing countries like mine, even how like, I go train in Japan, a lot of high technologies, but when you back to your countries, like you still have to base like, the real world, as you say, like between CT and M. Yeah.
Thank you for your thoughts.
Okay, anybody else have any comments or questions or just like to meet Sarath, Warlicks, and Takashi? If not, we'll wrap it up. Any closing remarks, Warlicks? We have a webcast tomorrow. Let me get that together, Warlicks, while you say your parting words, okay? Warlicks, okay. Let me get this up on the screen, okay? About the webcast tomorrow. It's from a place much like yours, Sarath, very rural. It's called Reunion Island off the coast of Africa. Oh, no, I'm sorry. It's in the Seychelles, which I'm sure it's a beautiful group of islands. You know what Seychelles is, right, Sarath?
Yeah, of course.
Yeah, it's kind of in your area of the world, actually. So it's a neuro anatomy lecture on tentorial incisura, and there's also going to be a Kahoot quiz. What do you think about that, Warlicks? Are you excited about that, having the Kahoot quiz?
Yes.
Aren't you excited? I mean, 10 questions, and you got to answer them live, and you get.
Yeah, but the medical, but the neurosurgical residents always get higher score than me, so I'm not going to show off.
Yeah, we'll have to get prizes and everything, but I mean, the neurosurgeon makes up the questions from the lecture, so it's relevant. And eventually, I guess, I'm going to put the information for Pragnesh. Just said he's interested, and let me put the information up there. Well, okay, we'll wrap it up, I guess, Warlicks. Does anybody else want just? I tell you, let me just some parting words. The role of this Zoom neurosurgery conferences is, we're yet to establish its place, but I think it's a very good time to network with people within the neurosurgical community after the presentation. And Sarath will be here for a minute or two. Warlicks, me, there's a couple other, we'll just mix and we'll be off camera, okay? So, what do you think, Warlicks? That's a good idea, huh, Warlicks?
Yeah, exactly.
Just say yeah. Okay, yeah. Very good, Sarath. Thank you very much.
Thank you. We look
forward to having more with you.
Of course, yes.
Yeah, that's right. Thank you.
Yeah.
Okay, and hang around, everybody. Thank you very much.
Thank you.
Thank you.
Thank you.